Good morning, everyone. Welcome to Pediatric Grand Round. Thank you for joining us today. We have two presenters to educate us on palliative care today. Our first presenter is Dr. Violet Borowicz, Department of Hematology, Oncology. She's a graduate of Drexel School of Medicine who completed her pediatric training at Alfred DuPont Hospital and completed her fellowship training in Hematology, Oncology at Children's National Medical Center in D.C. She joined the Carilion family in 2014 and became the Director of Care Connection for Children in 2017, and added on to her responsibility in 2019 as the Associate Program Director of Virginia Tech Carilion Pediatric Residency Program. And she's a huge hockey fan, which I know nothing about. Our second presenter is Dr. Christie Stewart from the Department of Internal Medicine. She's a graduate of UVA. She completed her training at Lancaster General Health System in family medicine and fellowships in palliative and supportive care and geriatric care. She worked for many years in Pennsylvania before joining Carilion in 2018. She serves as the Director of Palliative Medicine and Supportive Care, the Medical Director of Carilion Hospice, and the Director of Hospice and Palliative Care Fellowship. She loves to hike, and she's ready to educate us. Thank you for joining us today. Please welcome our presenters.
Yeah, well, thank you, everybody. We kind of want to present what pediatric palliative care is. There's still a lot of misconception about what pediatric palliative care is, and also talk about pediatric hospice care and how to consult us. This is a print that I get from, there's a group called Story People that makes these prints, and there are lives I can imagine without children, but none of them have the same laughter and noise. Neither of us have any financial disclosures. And our objectives are to define pediatric palliative care, distinguish between the differences between palliative care and hospice care, what the impact of pediatric palliative care is on quality of life, barriers to getting pediatric palliative care, when and how to consult us, and then when and how to consult hospice. So, a little bit about epidemiology. Pediatric palliative care really should not be limited to end of life. Approximately 53,000 children die in the U.S. a year, and 55% of these are less than a year of age, and only about 5,000 of those each year receive hospice services. Nearly 500,000 non-institutionalized children live with chronic life-threatening conditions. And there's an increasing prevalence just because of medical advances that have been made in neonatal care and oncologic care. And there are 17 million adults who are currently serving as caregiver to a seriously ill child. This is an older slide of just leading causes of infant death, leading causes of childhood death, and leading causes of adolescent death. So the leading causes in A, you can see congenital and chromosomal abnormalities are really the main focus for neonates, whereas accidents are a leading cause for adolescent death. And then accidents and other is what's listed under children between the ages of 1 and 14.
The reason we think it's important to present this is because palliative medicine is often mistaken as hospice care. It is mistaken just as reserved for children at end of life or people at end of life in general. And looking at that last epidemiology slide, if we were to truly reserve it just for children at end of life, we'd only be reaching 20% of the population that genuinely needs services. So I think that's really stunning statistic. So we're already underutilizing hospice services for children at end of life in general. We're really, really missing out on the broad spread of the population who need services.
So palliative care is really specialized medical care for any child who has a serious illness. It's appropriate at any stage and age for that illness and can be provided alongside curative treatment. So it's not an either or, it's really meant to be encompassing for more supportive care for families. We really focus on providing relief of symptoms, stress of illness, psychosocial factors that go into play when you're taking care of a chronically ill child. And the goal is to improve quality of life. And it's not just quality of life for the patients, but the families, the siblings, extended family members who are helping take care of these patients are really important to be included in these conversations. And again, it's based on what the needs of the family are, not the prognosis of the child.
It's really important to stress, because often in the hospital, even with the adult population and the pediatric population, we'll get a lot of, they're not ready for you yet. And like they're here with a chronic debilitating illness that is impacting their quality of life every single day. Therefore, they are ready for palliative services. But they might not like the word or what that word implies is how our scripting and how we're selling it to our patients. But if their lives are being impacted by a serious illness, they are ready for palliative services.
And those families that are coming in the hospital as frequently as they are, their lives are being impacted. Being in hospital impacts your life. And I will say we even had a family this week who I had met as an outpatient for palliative consult, and so mom actually asked for me when they got admitted just to be able to keep that continuity going. And that's part of where I want to continue to be involved, is get a relationship developed with these families early so that when they are here, I can help be another extension of the team.
That's really what it is. It's supporting the medical team in the jobs and tasks that they're doing and supporting the family and patient as the medical team is providing that care.
So the World Health Organization defines palliative care as, again, an approach to improve the quality of life of patients and their families with any problems that are associated with the life-threatening illnesses, prevention and relief of suffering. It is early identification and impeccable assessments and treatment of pain and other problems, physical, psychosocial, spiritual. It is a interdisciplinary team effort to provide palliative care. For the AAP, it actually addresses the needs of infants, children, adolescents, young adults to relieve suffering, improve their quality and enjoyment of life, facilitate informed decision-making. Communication is huge, and when you guys have a busy team, it's hard to spend the time that a family sometimes needs just for communication. And I know everybody has experienced this. The med students will get some piece of information, the residents will get another, the attendings will get another, and then I'll go in and get another piece of information that it helps to piecemeal their care together when they're kind of giving it little by little. It also helps to assist care coordination amongst the team. So one of my big things when I'm in the NICU is I say, especially when there are a lot of subspecialists getting involved in their care, we try to do care coordination meetings to make sure that the families understand if neurosurgery, neurology, GI, home, genetics, all the subspecialists that are involved, to get them at the table so that these conversations are being had broadly amongst the team as well. So the AAP actually has core commitments listed for pediatric palliative care and pediatric hospice care. So family-centered, patient-centered and family engaged, respecting and partnering with families and patients, pursuing care that is high quality, readily accessible, and equitable, providing care across the spectrum and lifespan, and then integrating into the continuum of care. And really, the goal is to be able to, everybody can provide basic palliative care and then consult us in a timely manner. And then improving care through research and quality improvement efforts. So again, it's most effective when it's incorporating an interdisciplinary team, building a strong relationship between the medical team, child, and family with effective communication, decision-making about ongoing medical treatment based upon goals and the total care, managing symptoms due to underlying disease, preparing for potential end-of-life conversations if it is needed, when it is needed, and then medical decision-making, identify the likelihood of an intervention meeting the goal of the care. Knowing and discussing the evidence for the benefits versus harm, and then define the time period in which the intervention would be expected to meet the goals. And then have a backup plan. If it doesn't occur, what will be the next thing, or if there's increased suffering or impact to the quality of life.
So going back to that a second, I think some of the challenges that providers get into, especially in an acute care hospital setting, is we are so used to looking at the next step. This is step one, this is step two, and we know the whole picture. We know where this is heading in the long run. We have that general knowledge, and we are focused on how to get from this place to the end of the track. And the families don't have that inherent knowledge, and it can feel overwhelming to them when you present all the steps. And sometimes what palliative medicine does is step back and talk to patients and families about their hopes and their goals and the things that are important to them with their value-based structure, and then realign the steps to meet the goal. And that's what we're specialty trained in, is sitting down and saying things like, what are we hoping for in the grand scheme of this treatment? Not, do we do the next step, but what are we hoping for? Because a lot of times, medical goals don't always match patient and family goals. And they can. Somebody just has to communicate between patients and families. And so we're almost a translator of sorts for that.
Again, sort of what our goal is within a disciplinary team is having physicians, nurses, social workers, chaplains, case managers, the bereavement specialists, child life specialists be involved in the care from beginning to end. Quality and safety, having an appropriate number of staff, ideally trained, paid specifically to provide palliative care, and then available for consultation anytime.
So there was a project done through the Center to Advance Palliative Care and the American Association of Hospice and Palliative Care and the NHPC called the National Consensus Project. And what they really tried to do was standardize and align what services are provided by a palliative care team. Because it feels a little bit, especially because it's a newer specialty, it's only been a specialty since 2006. Only recognized by the American Medical Association since 2008 was the first time you could actually board. So we're fairly baby specialty in the grand scheme of medical specialties, which also makes us a little bit of a nebulous specialty, especially when I'm sitting there and hearing myself from the audience going, so you talk to people, that's your specialty. And I say, yes, that is my specialty. And I talk to families, what do you do? I'm here to communicate. That's it. That's what I'm here to do. So they tried to develop this standardized approach to what defines quality palliative care. So a big part of that is an interdisciplinary team. And even when you look at regulations for training within fellowships, the interprofessional education is foundational for our fellowship. But as far as components of palliative care consultation, in order to call ourselves a quality palliative team, we need to be meeting all of these points within a patient and family assessment, including what is their understanding of their condition, including physical examination findings, including past medical history, including a review of the recommended treatments, including a review of prognosis. By the way, grim and tenuous are not prognoses. That tends to be what I see in the chart most often. Their comorbid conditions, including their psychiatric conditions of both the patient and the family members, as far as how that impacts quality of life and care. We do a thorough review of medications. We do a thorough review of social determinants of health. We do a thorough review of social and cultural factors that impact care, including assessing caregiver burnout and caregiver support. We address emotional concerns. We address the spiritual concerns, and we actually are required to do anticipatory grief assessments. That's what you get in a quality palliative concept. So it is not a small task. And it's also not a task that standard medical care trains and prepares us to be able to perform. So, hence why it's its own specialty. Yeah.
But I would argue, here, go back, that's a good assessment. That's a daggone good assessment. And we're trained to do physical exam, past medical, family, social history, comorbid med review. I would hope that we're asking good social questions. I applaud what you do. I'm just saying that a good doctor does that.
Hence, the idea of every physician should have fundamental training in primary palliative care, right? And specialty services are reserved for more complex situations. Just like every physician should have basic training in pain management. They should know how to treat a patient's pain. But there are times when the pain situation gets exceptionally complex and specialty care is provided. So I don't disagree with you, Dr. Keyes. In fact, you've made our point that foundational primary palliative care is an essential part of medical training, and I applaud that. Thank you.
a comment from Dr. Ward. There are time limitations that a good physician may not be able to do all those components.
But I'm going to argue they're a physician too. So their specialty has said, we're going to carve out this time. So I'm not sure we're shifting that responsibility. I don't want to get off on a
sharing. We'll say we're sharing that responsibility, not shifting that responsibility.
My goal to come in is not to take over the medical care, and I've always said this to families, like, I'm not the primary decision maker here. Even with the family that I had recently, I told them I'm not in charge, but I've talked to the attending, and this is what we talked about. She's going to come and talk to you after she was done with whatever she was doing. But my goal is to help be an extra added layer of support for the family, to be able to convey what they may not necessarily tell the team. Because I will say, like, Mom told me something completely different, and I went and talked to the nurse, and I talked to Dr. Wynn, and both of them were like, that's not what she told us. And I was like, I don't know what to tell you. Like, this is just how, because Mom knew me, so she was telling me different things because I have that established relationship with her. And so there are components that, again, we're not taking over, we're sharing. I really don't, I don't intend to be a hospitalist or an ICU doc or a NICU doc at all. Nope. So again, this is actually something that I pulled from this perinatal pathway for babies with palliative care needs in this component of Together for Short Lives from the UK. There are a lot of different times where palliative care gets involved, and I often hear this from the NICU, especially, like, it's not time yet, it's not time yet, it's not time yet. And so there's this big gap, that bottom one, where it's not apparent, and then all of a sudden it starts suddenly when the realization comes that palliative care is needed. Sometimes palliative care is involved from the time of diagnosis. I actually get a lot of MFM consults that I do in the outpatient setting to help families who know we have lethal fetal conditions, and we come up with a birth plan and come up with a plan for labor and delivery for what to meet the needs of what the family wants during the birth process and what they want for comfort care after birth. And we know that if the child may live longer, I discuss potential going home on hospice, and so I have these consults that I do when we know lethal fetal conditions from the beginning. And there are times, there's getting palliative involved in the beginning. It may be ebbs and flows where palliative gets more involved or less involved. And then there's also the gradual shift from solely curative to end of life. And that's, I think, one of the biggest things that I have with this slide itself is it says shift from curative to palliative. It should be curative to end of life, because palliative is not end of life care. Dr. Ward also said medicine is evolving and demands are
changing. Oh, yeah.
As well, and palliative care is incredibly helpful for our line of work. Thank you, Dr. Ward.
Dr. Ward, thank you.
Dr. Ward is one of my biggest supporters. He keeps me very busy here. So differences between pediatric and adult palliative care. So again, patients in age range, we all already know, just age-related differences. The wide range of diagnoses and disease trajectories. Care of the patient in a pediatric takes place over many, many, many years.
We tend to see them late into the stages of a chronic disease state. So the prognosis usually once they attend adult palliative services is mainly in the 6 months to 2 years realm. We would like it to be earlier, but it's hard sometimes to convince adults to come to a physicianal position. I think for children, they're working with those chronic disease states for even more years. So.
Another big thing is involving parents in the decision-making. They're minors, they're not making decisions for themselves, so the parents are the primary decision makers. And then also just meeting the needs of the developmental stages of the population we're serving.
So I do think it's important that we address the idea of pediatric hospice care, mainly because the term palliative and hospice generally are used interchangeably, and it's one of those things that if you ever do that, you'll see me kind of wince just a little bit behind your care. So what we'll say, all hospice care is palliative, but not all palliative care is hospice, okay? And I even generally go a step further to say all medical care should be palliative. It should be based on quality of life, it should be based on comfort and symptom management, and it should be based on the goals of the patient and family. Now, the majority of it can be practiced by a primary care pediatrician in the community or a hospitalist. I'm not saying you need a specialist for every single case, but I will generally argue that all medical care should always be palliative. So focusing on pediatric hospice care, what makes this different from pediatric palliative care is the really kind of unicentric focus on pain, symptoms, and stress during the terminal phase of illness. It is reserved for patients with an estimated prognosis of 6 months or less. How good are physicians and providers at determining a prognosis of 6 months or less? We're terrible. We are terrible. So that's why the average duration of patients in hospice is roughly 2 weeks on a national basis, because that's how long it takes us to determine that their prognosis is less than 6 months. So what we generally do is say, well, ask a surprise question. Would you be surprised if your patient lived another year? And if the answer is yes, I would be surprised if this patient were able to live for 1 full year, then they are appropriate for hospice services. Okay, so that's generally the marker. The beautiful thing about pediatric hospice care specifically is that the Patient Protection and Affordable Care Act specifies that children enrolled in Medicaid or the Children's Health Insurance Program, CHIP, can concurrently receive hospice services and life-extending disease-directed care. So they still should have a terminal prognosis of less than 6 months or a surprise question of less than a year, but they can continue to receive hospitalizations, antibiotics, vent support, chemotherapy, radiation therapy. They can continue to receive those treatments concurrently with hospice services, an additional layer of support. It's not something adults at this point are offered. It's been floated, but it hasn't been passed or approved yet. They're using hospice as the model. And Kim Ramsey said, all medical care should be palliative is a great point that unfortunately is often not well understood by the medical team. I concur. Thank you for that point. Okay. I just think we need to reframe the word palliative and what it means. I think we need to change the language and the scripting. So, pediatric hospice care is mandated by federal and state regulations. So federal and state regulations determines what services are provided and how those services are regulated. Hospice services involve a full interdisciplinary team, just as pediatric palliative care is meant to, including physicians, nursing, social workers, chaplains, bereavement counselors, volunteers, therapists, including physical, occupational, speech, massage therapy, pet therapy. There's a huge array of services that different hospice agencies will be able to provide. But it really is an all-inclusive team that all collaborates and works together for the good of the patient. Weekly meetings take place where we all sit down, we all talk about the patients that we are serving, the difficulties each member of the team may see from a different direction. As Dr. Borowicz alluded to, the idea that different team members may strike different connections and receive different pieces of information that we are then meant to integrate and collaborate with as an entire team. Okay? It is financed as an all-inclusive per diem rate. So when a patient enrolls in hospice services, the insurance is paying hospice to meet the medical needs of the patient, and hospice is responsible for 100% of the medical needs of that patient related to the disease for which they qualify for hospice services. So that all-inclusive per diem rate gives the patient and family 24-hour in-person on-call service, in-person home visits made by medical providers, all medical equipment, all related medications, includes volunteer services, spiritual care, and bereavement support for a minimum of 1 year after a patient's death. So we support the family well beyond even end of life, okay? It's most often provided in the home setting, but it can be provided in an inpatient center. There are 4 covered levels of care for hospice services based on patient need. Inpatient services for pain and symptoms that cannot be managed in a home setting is one of those levels of care. So a hospice team can admit a patient into the hospital under a general inpatient level of care to meet needs that cannot be provided in a home setting. And with pediatric patients, we tend to take more advantage of this, given the fact that they're often concurrently receiving curative medical therapies. Questions about that? Regulations are my jam, so that's what we need. Okay. So pediatric palliative care and pediatric hospice care are essential aspects of medical care for any patient with a life-threatening, serious, or terminal medical condition, even prior to the need for end-of-life care. Okay? Pediatric hospice care is growing, but still it's harder to obtain than hospice care for adults. There's a general lack of capacity to care for children, infants, adolescents due to the complexity of the medical care, the alignment with curative treatment potentially, and the cost for pediatric treatment teams. Insurance coverage restrictions and limitations doesn't tend to come into play as much in the pediatric, because usually by the time they're diagnosed with such a critical life-threatening illness, they're kind of on the Medicaid and CHIP plan at that point. Private insurance companies tend to not cover those children as well. But if they are being covered, especially in the trajectory where the condition was not considered as life-threatening and was anticipated, there could run into potential, insurance coverage limitations. So as far as differences, hospice care and palliative care are both focused on aggressive pain, symptom management, and quality of life management. Hospice care is for children with less than 6 months in the doctor's best estimate, and what I tell the providers is you have to have 51% certainty, okay? It's not that 6 months hospice services cuts off. I've had patients on hospice services for 5 to 6 years, because every time I recertify them for services, I can always say, in my best guess, their prognosis is less than 6 months. I don't have to be right, okay? Where palliative medicine is for any serious chronic or life-limiting illness. They both care philosophy center around team approach. They both involve patient and family dynamics. With hospice care, in general, they're not seeking curative measures or return to the hospital, although sometimes they are, especially in the pediatric population. But with palliative medicine, they absolutely can seek any type of curative hospitalization or other treatment option. Okay.
Yeah. So one of the things with pediatric hospice care is it really has been a growing field. When I first started sort of doing my own research into palliative when I was a resident, there was nothing really that it was super hard to find any place in hospice that would take a pediatric patient. This organization, the Children's Hospice International, was actually a nonprofit founded in 1983 to include children in existing and developing hospice, palliative, and home care programs. So it's an all-inclusive care for children and their families to provide the continuum of care and gives access to care for children and family who meet the criteria of the diagnosis of a life-threatening condition.
So I do think it's important that we talk a little bit about the impact of why palliative medicine became its own specialty and why we're here promoting it to you. So there was a study done that showed that 70% of Americans have absolutely no knowledge about palliative care services. Okay? It's not a required part of medical training. It's not well known in the community. But when you took the word palliative out and you just described what palliative services does and what they offer, as we did for you, 92% of Americans said they would want palliative medicine for themselves or for their loved ones, including specifically within the pediatric population. 86% would be likely to consider pediatric palliative care for their child during cancer treatments, and 89% think that pediatric palliative services should be available at every hospital that cares for children. So even though they don't know about it, they want it. They want what we have to offer here. There have been multiple studies, including within the pediatric population, that shows that the early integration of pediatric palliative services improves clinical outcomes. It improves compliance with medical care because we're helping to manage symptoms and caregiver strain and stress. It improves quality of life, and it improves the fundamental experience. It increases the frequency of what they consider life-enjoyable experiences. And what a cool thing to be able to offer your patients. It improves patient and family satisfaction with care. It reduces caregiver burden and improves symptom management. And then additional studies have shown that patients who are happier with the care they receive are more compliant with the care that they receive. So it all works together and fundamentally to help each other. It also significantly reduces healthcare costs. There's a reason insurance companies pay for our services, because for paying for our services, they're saving money down the road by reducing hospitalizations and reducing ED utilization, which is also why concurrent hospice and curative services for children are allowed, because hospice services prevent hospitalizations and ED utilization. So it saves insurance companies up to, I think it's like somewhere between $100,000 to $200,000 per patient, which is not an insignificant amount of money.
So, like we talk about, who and when is this appropriate for? So, early integration is key. I know I've had a big focus of trying to get involved early in the NICU because, again, when these families go home and they have chronic illnesses, if they get readmitted to the PICU or PEDS floor, they can ask for me because I can help provide that continuity of care, especially when I've already known their history from the NICU. Additionally, I do see them as a consult in the outpatient setting, so I help with symptom management in the outpatient setting as well. I've had a family who I've taken care of, he's 3 now, that I've met since the NICU, and I weaned him off of med, and we were watching, things were going great, and Mom just called me out of the blue almost a year later, like, things were not going well. We started I did the med back up, and his weight gain started to improve. And so there's a lot of things that, you know, they know me, I can be a continuity of care and help in between hospitalizations, outpatient care, especially when there's a lot of those specialists involved. And it's helpful for when curative treatment is possible but may fail. Intensive long-term treatment maintains quality of life for chronic, potentially progressive conditions, progressive conditions without a curative option, and then non-progressive, irreversible conditions.
So those are the patients we're trying to target as far as palliative care consultations are concerned. We're not trying to take every single patient in the hospital or every single pediatric patient that comes to the doctor's office. So if we're targeting consults for the most meaningful group of populations, these are the conditions that we would target.
This is a kind of a quick list of just things that are helpful. So any critical illness or injury, severe malnutrition, malignancies, which I do with my oncology patients already. Spinal muscular atrophy, even though there has been a lot of improvement in SMA, there's still a good population to refer to palliative. Duchenne's muscular dystrophy is a big one, and I still remember I had first started here in 2014 and got a consult on a 15-year-old with Duchenne's muscular dystrophy who was dying, and Mom and Dad refused to let me go in there because they did not want me to tell him he was dying. And so I did all the work. I got all the hospice set up, and then I put Dr. Miller in charge of everything because they never let me meet the patient. But it was different for a different set of siblings that I had later on with Duchenne's muscular dystrophy because I had established care with them. They knew me. So when they, several years later, were in the PICU and dying, those conversations were slow, but we were able to have them a little bit more with the patient, with the family, because they knew me ahead of time. With that first patient, they had no idea who I was, and they really just thought I was the deaf doctor. So they didn't want me, which is, I don't take offense to, but it's why getting involved early is really beneficial for these families so that we can have these ongoing relationships so that when those conversations do have to take place, it's a little bit easier for the family to be able to have those discussions.
And if there's one scripting in my years of doing this that I'm going to discourage is, we have nothing else to offer, so we're going to call the palliative team. Those words ever come out of anyone's mouth, I hope the attending immediately curb that. But you would be amazed how often, because we are reserved for so late in the illness, so how could we possibly, from a cultural perspective, dissociate ourselves with end-of-life care to provide needed services if we're only being brought in at end-of-life? So, to speak to your point, Dr. Keyes, as far as that's a good medical assessment, I don't disagree, but the relationship and what that means over time is also really critical in providing services.
Oh, that's long.
All right, yeah, that was a lovely chat. All right. Oh, that is long.
It's very long.
That's all right. Okay, Dr. Ward, back to Dr. Keyes' comment, shifting responsibility. I used to totally agree with that. For resident training, yes, we need to train our residents not to look to shift responsibility, but from a practical standpoint in the trenches. These important, complex, hard conversations with family easily can take multiple hours, 2 or 3 a day, and can take several days of discussions and coordination. And that's challenging for a PEDS hospitalist and PICU attending. And it's very emotional, these conversations for all parties. We're talking about a child dying here, or living,
or living. There are other patient needs that also need our time, and it's not fair for the family to for us to cut them short with these important discussions. My experience with training and fellowship where we worked alongside the palliative team is I found them to be incredibly helpful and time-saving for us to focus on more critical issues. Much of the critical care PEDS literature supports multiple aspects of involving PEDS palliative care early. So here's the other thing I'll say. These conversations are very time-intensive and very emotionally draining. I'm not going to dissuade that or this. If I were handed a scalpel and I was told to go into an OR and perform an appendectomy, I could do it. I was trained on that way back in the day. I have done less than 10, okay? It is going to take me a significant amount of time to go into an OR suite and do an appendectomy. If I handed that same scalpel to a very, very well-trained surgeon, they're going to do it smoother, better, with less complications in a shorter period of time, okay? You all are responsible for these conversations. This is what we do all day, every day. And because of that, we have learned techniques that make us more efficient, and we also have built up a stamina for these emotional relationships. So we can teach skill sets as well in doing it. I'm not saying the goal is efficiency, but there is something to the practice that makes it better. And so even if you come and do a rotation with the palliative services, adult or pediatrics, we're going to encourage you on techniques to make your training more efficient and how to have difficult conversations. So.
And these conversations are not necessarily easy for us either, no. But we just do them more often.
Right.
I will say I have an MFM consult that I have to do today, and her due date is a week before mine. So I'm already like feeling the pressure of having to have this conversation with a mom while I'm pregnant as well. But again, it is something that we do. We have these emotional conversations, and it does take time. You got to give families space to have those emotions, which you guys don't always have time for, especially now that we're experiencing winter in whatever month we're in now in the PEDS world. And so that's where we come into play. Again, just another long list of things. And, you know, it really fits for everything. Prematurity, birth defects, birth asphyxia, HIE, congenital anomalies are a big thing that I do in the NICU. Genetic things that we don't even actually have diagnoses for are also big. I have a patient who has Prader-Willi. She's doing well overall. I see them every 6 months when they come for their endocrine appointments just to check in and make sure they're doing okay and don't need anything more. And it's because mom wants to come and see me. So these families, you know, it's good to get involved early.
And I am going to also say that the unfortunate aftermaths of the COVID-19 pandemic and how that is impacting long-term life and health conditions has been a very, very big deal for the palliative care community. We've all attended special courses on how we support patients and families through that. So even from that perspective, just knowing their services out there. So as far as when is it appropriate? It's appropriate at time of diagnosis. In general, palliative services are best served with the community if they meet a palliative physician 6 to 8 weeks after time of diagnosis. So it's not with the initial necessarily of their chronic medical conditions, it's within 6 to 8 weeks to provide supportive care. As far as the need for early integration, symptom management, we've talked about that, attention to quality of life, and potential communication about end of life and what that looks like for parents and children. We know that providers generally wait too long. They still define us as equivocal to hospice services, and they refer once curative measures are no longer an option. So I hope this presentation has dissuaded that interchangeable terminology from your lexicon. It also emphasizes the need for an increased number of services, as well as more education towards supportive and palliative measurements during diagnosis and treatment. There has been a bill introduced to the House about why palliative medicine is not a fundamental part of medical training, and we are trying to overturn that. You have to do a rotation in cardiology, and you have to do a rotation in pulmonology, and those are essential rotations for medical care. I'm not saying they're not. Why is palliative medicine not integrated within all medical care, not just for providers, but for social workers and chaplains and any nurses and anyone who serves in the medical community? So we talked a little bit about barriers. We kind of danced around this. We've talked about the unfamiliarity, okay? We talked about the hospice care model, and I love the hospice care model. Obviously, I'm trained in the hospice care model, but there is something about we have them, now you have them. right? And what it does is removes death as a normal experience within medical practice, thereby making us not very comfortable with this idea. There are, in general, low reimbursements for treatments that improve quality of life over time, and oftentimes we force patients to choose, right? You're not ready for palliative. Oh, I don't want to go palliative because I want my chemotherapy or whatever have you. With both pediatric and non-pediatric healthcare professionals, there's this notion of it's one or the other. It can't be both.
Limited financial resources we've talked about, and then limited access to specialty care in rural areas is another big thing. Communication, I think you know that our big thing is communication. False hope for a cure can also sometimes be problematic. I try to work with the hopes that families have and try to shift. A lot of it is, when we talk even about withdrawal of care, ethically there is no difference between not providing, not intubating the patient and withdrawing or extubating the patient. But it is hard to wrap your mind around that you are taking something away from your child. Having those conversations about what this actually means for them, that you're not stopping care for your kid, you're shifting your focus on making sure that your child is comfortable and taken care of. And that's a huge part of the conversations that we have if and when it does come to those.
I know there's a whole lecture around the idea of false hope, and I will often argue that you can give families false hope, but you actually are not capable of taking away hope. You don't have that kind of omnipotent power over a patient or family's life. You can certainly misdirect them with inappropriate information, but even holding reality does not take away hope. And if we had a nickel for every time I heard, we are hoping for the miracle, and we say, you should. Please continue to hope for that miracle and pray for it while we are addressing what is happening with your child in this time. So the patients are very capable of holding this place.
This is from Dr. Hogan. In fellowship, we stopped using the term withdrawal of care and started using changing goals of care, transitioning to comfort care, and the like. Yes.
I often say we are going to stop prolonging the dying process. That's what I generally say. I don't like the word life support, because then withdrawal of life support, what does that mean? Death support? It doesn't feel appropriate. So I often say the fundamental aspect of the condition is that your loved one is dying. We are just going to stop prolonging that process.
Jim Ramsey says, I like those terms. Inappropriate continuation of the use of advanced life-saving technology. We, as pediatricians, have a hard time letting kids die if it is time to. I mean, in our nature, we are supposed to fix things. As physicians, in general, we went to med school to fix stuff and make kids better, make people better. So we have a hard time withdrawing ourselves and learning that there has to be a time where this isn't going to be effective anymore. And then ethical and legal issues. Inappropriate eligibility criteria, fragmented care. Again, the reason I like to get involved early is because having that continuity of care, having that relationship developed is really big for a lot of these families. Inadequate assessment and management of symptoms. Lack of research.
Getting better.
Lack of training and expertise, even in pediatric oncology. I will say that one of the main reasons I actually got interested in pediatric palliative care was when I was an intern. I witnessed one of the worst deaths I'd ever seen for a relapsed leukemia patient because my pediatric oncology attending would not have the conversation about them dying. And I knew I wanted to go in hem-onc, and I said, I cannot be that oncologist who cannot have these conversations, so I started self-training because I needed to. And that's what actually prompted me to do what I do now. Making the case.
So the idea behind this slide is Dr. Diane Meyer is the founder of the Center to Advance Palliative Care, and I want her to give a lecture. And the idea behind, because it's a hospice and palliative medicine fellowship, so the idea of hospice and palliative medicine is kind of in the training and in the name. They're closely tied to each other. But there's a big debate on whether we dissociate those terms. Do we say you are certified in hospice or you are certified in palliative care, and we kind of define ourselves differently. And what I liked was Diane Meyer said, I don't care what you call us, just get us in the room, okay? So if the word palliative is bringing up poor emotional response, we could be called supportive care. We could be called dignity-preserving care. We could be called concurrent care, integrative care. I don't care. I don't care what you call us. Just get us in the room.
The team at DC Children's, when I was a fellow, they were referred to as the PANDA team, since DC Children's has the Dr. Bear logo. So their PANDA team was the Pediatric Advanced Needs Assessment team. That was their palliative care team. And actually, several years ago, one of our surgeons at the time told me that I needed to change the name of my field of medicine, and I was like, that's not on me to do.
Although there is a shift that we're talking about sometimes, and even on our jackets, we now have palliative and supportive care. So if the word palliative stimulates something bad, we don't care. Just get us in.
So, how to introduce us. Identify the fear. We are not hospice. We are not end of life. Again, we are supportive. We are complementary. We are here to help.
My fellows laugh at me. I walk into the room. I'm Dr. Stewart with the palliative care team. I am not hospice. It's like a big hyphenated name, okay? So.
Reassurance. So you're still involved. Even getting us involved, you're still the main person involved in their care. You can still receive all the treatment that you're getting. That's not going to be taken away. Normalizing the process. So asking, and I have several docs to do this, like telling families that they're getting me involved to help with care coordination, with symptom management, with psychosocial stuff going on. And then targeting what's important to the family. So helping with symptoms, helping with the stress, helping with quality of life.
So this is actually a patient-tested script on how to introduce palliative services to a patient or family. It's specialized medical care for people living with serious illness. This type of care is focused on providing you with relief from symptoms, pain, and stress of illness, whatever the diagnosis. The goal is to improve quality of life. It's provided by a whole team, physicians, nurses, and other specialists that are going to work alongside your other doctors, nurses, and team members. They are an extra layer of support. And it's appropriate at any age and any stage, and you can have curative treatment. So when you script it like this, let's be honest, who doesn't want Dr. Borowicz and palliative team in the room?
Dr. Keene is asking how to get me involved in an outpatient setting. I have a slide coming up.
Yep.
Here we go. So inpatient, there is a PEDS palliative specific order to refer to me. The adult palliative team will not be covering PEDS pain management order, so if it is a PEDS pain management that is separate from palliative care, consult put the PEDS pain management order in, which is still for me, but we would like all consults to start going through Perfect Serve. Mm-hmm. So there is a plan, especially with me going on maternity leave, for the adult palliative team to actually cover calls for palliative. So putting these consults in through Perfect Serve, through the Pediatric Palliative Care group. When I'm here, fellows will staff with me, and if I'm not, the adult palliative physicians are going to be my backup. Services are going to be available right now, Monday through Friday, with the hope that it'll eventually go to the weekend.
Yes.
And weekend and overnight coverage is available when I'm on call for HEMONC, mostly because I cannot be on call 24/7.
But there are hopefully plans to expand that coverage as well.
Outpatient, there is a referral for my outpatient clinic, so you just put in the ambulatory referral for PEDS palliative care. It is helpful in the outpatient setting if you do send me an in-basket, because sometimes the referral shell does not drop into my secretary's queue, and so if I know that a referral has been placed in the outpatient setting, I can tell her to go look for it in that patient's chart. And then inpatient consults, I usually try to do a follow-up within 2 to 3 weeks after discharge. I try to work with the families. If they have another appointment that they're doing in person, I'll try to make sure it's scheduled the same day, because again, I'm not trying to be a burden to the family, so I'm not trying to have them come for separate visits. That's an additional drive, especially some of my families that live a couple hours out. And because of COVID, actually, the nice thing that's happened is I've actually been able to do video visits for a lot of families now, especially those with trachs and vents, because it's actually been a lot easier for families not to have to drag their trach child out of the house. Thank you, Dr. Worth.
How exciting.
Yeah,
I'm giving calls.
Again, okay, so for pediatric hospice care, this has grown tremendously since I started doing this when I was a resident, like the number of hospice that's available for pediatric. Carilion Hospice does take pediatrics, which I honestly did not know until a couple of years ago.
Yeah, we actually have a specialty pediatric-based program.
Yes. So. And we have been working together to build pediatric order sets and pediatric education for the hospice team at Carilion. Gentle Shepherd also does take pediatric patients. And then for the Danville area, Mountain Valley Hospice has a Kids Path program. And then there are other places around Virginia and West Virginia too. Again, this is Carilion Hospice, so how to refer. They service Roanoke, Franklin County, and New River Valley. Yep. Services provided, we've already reviewed music therapy, massage therapy. We had a patient who, several months ago, we were having this ongoing discussion about trying to get them on hospice. They've been a very chronic, well-known patient here for 7 years. And Mom was very resistant to it at first. She finally signed on to hospice, and actually when I last saw her, she was like, he loves the massage therapy that he gets. He loves the music therapy that he gets. All these services that were not in the home previously but are provided by hospice, this patient has really, and family has really enjoyed for him. So the outpatient referral, there's an ambulatory referral for hospice, and then inpatient just consult to hospice. And then there's the website for the Carilion Clinic Hospice and the phone number.
If you have any questions, is this patient appropriate? What do you think? First of all, the hospice team is always happy to go out and do an introductory visit to kind of discuss services, and it's no charge, and they'll meet the patient family in the home, they'll meet the patient and family in the hospital, whatever works best for that individual. So even if you're not sure, I'd say, go ahead and place the referral just for the introductory visit. I can often kind of sell it to patients and families like that as well. Just meet with them. Just hear what they have to say. If you don't like it, no one's obligating you to anything. So.
Dave Ward said Mountain Valley Hospice also has an office in Hillsville. Another thing that I wanted to point out that came up recently, actually, for a patient that we had end of life, there was withdrawal of care, and 24 hours later, the resident called me and asked me about symptom management, and I asked, did the comfort care order set get put in, and he said, the what? So we have a comfort care order set. If a patient has orders for withdrawal of care, end of life, there is an actual comfort care order set that is built for peds that can be put into place to help with symptom management, and should be put into place when there is going to be withdrawal of care in the hospital.
All pre-populated. They do all the thinking for you. All you got to do is check the boxes, and you won't miss them. So.
And once that comfort care order set got put in, everything was much smoother for symptom management at the end of life for that patient.
Prevents middle of the night phone calls to you guys.
So there are resources. EQIP does have resources talking about serious illness.
The Center to Advance Palliative Care.org is a membership-based service that Carilion Roanoke Memorial Hospital has bought the membership for, yay. It is free to everyone with a CarilionClinic.org email address. You sign up for a class, and they have specific modules that last anywhere from 30 to 60 minutes about communicating serious illness, pain and symptom management, even in high-risk populations. And they are all pediatric provider appropriate. So I mean, they're definitely, in general, a little more adult geared, especially when it comes to specific medications, but pediatric providers have weighed in on every one of those modules. So.
We do have our MOC questions. So a 12-year-old boy's friend died of complications from heart failure a few weeks ago. Patient's mother reaches out with concerns regarding her son's behavior, includes intermittent crying, inattention in the classroom, withdrawing from the company of his friends, simultaneously worrying about their health. She expresses concern about him being depressed and worries about this persisting, particularly with a family history of mood disorders. She would like advice on the next step. So of the following, the most appropriate approach regarding his mother's concerns is ask him to be brought in as soon as possible to complete a behavioral checklist, instruct his parents to avoid discussion of his behaviors and redirect him if he tries to talk about his friend's death, normalize his behaviors as grief and discuss treatment options. If his behaviors continue beyond the context of grieving for his friend, then start treatment for depression with a selective serotonin reuptake inhibitor, and refer him to a psychologist.
Quite true.
Very quiet, yeah. So, normalizing his behaviors, discussing treatment options if they continue beyond the context of grief. It's actually good to have these discussions. You know, even preteens, teens, they know what's going on, and it's important to have those conversations. It's hard for families sometimes to do it, and so you as the primary care provider, primary care physician, may be the one having those conversations with the patient, too.
Just so you know, every hospice agency actually has to have bereavement counseling coordination services that are widely available to the community, even if the person was not involved in hospice care. So if you have a grieving child and you're not sure where to make a referral, sometimes calling a hospice agency will help plug them into appropriate age-related services, even if the patient was never involved in hospice.
A 15-year-old adolescent boy with Duchenne's is currently admitted for worsening heart failure. In discussions with the team, the patient's mother conveys recognition that his disease is progressing despite therapy and that this will lead to his death. She wants her son to be at home to maximize his quality of life and does not want to spend his last days in the hospital. She agrees to a DNR. Preparations are made to discharge under hospice. As the patient's situation is reviewed with the care coordinator, the patient's mother is overheard telling the aunt that she is hoping for a cure and that one day he will help others with similar conditions. The care coordinator expresses concerns that the patient's mother may not recognize the implications of going home with hospice care and that the team may need to revisit this before discharge. So the best next step is to conduct an urgent multidisciplinary meeting prior to discharge, consult the ethics committee, continue with facilitating discharge from the hospital and admission to home hospice, discuss with his mother the concern that she may not understand the purpose of palliative milrinone. So C is actually the answer. Having those conversations will continue. We know that families are going to always have that hope. Like Dr. Stewart said, you can't take away that hope that they have.
You don't want to take away that hope.
So even with the family that I most recently put on hospice, there was a lot of resistance to it, but hospice continued to meet with them, had this conversation, mom accepted, and she's really starting to see the benefits of what hospice can provide for her child. And because hospice is there, available 24/7, they really are developing that long-term relationship that's helping with that communication ongoing. All right, one more. A 9-year-old with a progressive sarcoma has received support from her primary care pediatrician throughout her treatment. Despite multiple therapies, the cancer has continued to spread. Her parents, under the guidance of patient oncology and palliative care teams, have elected to enroll her in hospice for continued symptom-directed care at home. The child has been asking her parents what's going to happen to her, and the parents are struggling with what to tell their daughter about her terminal diagnosis and ask her pediatrician for advice. So the most accurate statement to share is that A, have a limited impact because she's unable to comprehend the finality of death at her age. B, increase her risk of depression and should be approached with caution. C, likely to reduce her anxiety if she's able to participate in an honest, open discussion. And D, make them more likely to experience regret. Yes. So I will say I actually had, back in 2016, one of my AML patients who I had sent home on hospice when she was 9, the parents could not talk to her about what was going on. And I went to their house to have a conversation with their daughter about the fact that she was dying, just to talk about this, because they really struggled with doing it. And so I went to go have that, so that to help the family out with that conversation. And again, that's sort of where our role will come in, not just us, but you as pediatricians too, seeing these families that may be coming to you for advice because you guys also have an established relationship with them.
Questions?
Oh, sit down.
I think someone asked about what was in the comfort order set.
Oh.
It's been a while since I've looked at it. Symptom management for not just pain, but dyspnea, nausea, agitation, confusion, and a whole slew of nursing orders about directed assessments towards symptom management, vital sign checking, and things like that. So it covers diet, it covers code status, it covers symptom management, it covers nursing, communication and nursing orders.
One last comment. I just want to thank you for your presentation. I don't want my previous remarks to be misconstrued in any way. I fully support palliative care. Sometimes you don't know where people are coming from. I'm coming from two perspectives. One is yesterday, when the Joint Commission was here, there was a citation that social histories, family histories, et cetera, were not on people's charts. So I don't want anybody in this room to think that part of a physical exam is not taking a social history. We have young learners here. I'm also a generalist, so I believe that I need to know some things about cardiology, some things about GI. I need to know some things about palliative care. You guys are the experts, but I need to be able to do some of it. And I find that sometimes I go to a room and I ask social questions, and then my team is aghast at the questions I ask. We are invited into a family because that's our role in society. So I ask sometimes very personal questions because I need to know the environment of that child. And that's not your role. It's our role. So I think we all need to be better at all of this. But thank you, and I do fully support what you do, and I think you understand that. Also, just to be clear, I have very personal experience with hospice. I have a hospice care patient in my home right now, and my father died in hospice care, so I appreciate those services. Thank you.
It does take a village, right? Medical care is too complex, too time-consuming. It does take a village. So I totally agree. Promoting excellent primary palliative care practices is your fundamental responsibility, and knowing when to call for help is also your fundamental responsibility. So I couldn't agree more.
And for the learners on the phone, the important takeaway is you guys should be taking a social history, a family history.
From documenting it.
And documenting it.
I made one comment earlier on is that you talk to the patient, listen to the patient, and I think that's the critical piece. That's what I think Dr. Keith said. I appreciate Dr. Ward's comments. I watched a lot of people try to build practice. I've watched a lot of people building practice. What the patient wants, they want to hear. You change the name and ask them that question.
I will say one of the big questions that I often ask families in terms of social history is what support do you have outside of here? Because especially for these kids with chronic illnesses, do you have your parents? Because we don't all, I mean, my husband and I are here alone, so we don't have social support outside of work. And so knowing if they have family members around, if they have friends around is huge, especially when they have a child with a chronic illness. And that is one of the main questions I try to get at with social history from these families.
And what gives you strength? That's my other favorite one. What gives you strength as you navigate this path? I like that one too.
All right, I think we're a little over time.
Thank you very much.